Moltes gràcies, bon dia a tothom. Well, it is indeed a pleasure for me to do this job today. We have seen in the previous minutes that we are doing well as an institute, and I would even say that we are doing very well as compared, for example, with the other six institutes that are health institutes of the Ministry of Science. We are also maintaining a very good position, and this is even more prominent if we consider our funds, which is 38 million, and our production. This is very high, and we can be very happy. But we want not only to keep doing well, but to do better. And there are many things that are necessary to do better, but there are two that are very convenient. And one is to increase the identification of our investigators with our institute. The institute is not that white building over there. It is the hospital and the institute and the university. And increasing this identification is very important. And also to find a focus for our activity, to find a niche that could, in which we could really excel. And this is translational research. And these scientific sessions and this 14th lecture should serve to both purposes. And for that reason, our general manager, Dr. De Sancho, that really acted as a promoter of research and had a lot of initiative and really supported extraordinarily research, as Joan Comella mentioned during his recent talk, suggested to the director of the institute and to the scientific committee that this year the talk should be on translational medicine. Well, translation is movement, and translational research is movement along a very long and complex way. And this year we were supposed to cover the last part of this way, and Dr. De Sancho suggested that we should invite a clinician. So we selected Dr. Michel Ovize, and we invited him, and I think that he is a perfect speaker for this purpose. He is, in fact, a clinician. He is a cardiologist, and he had his medical training, but after the medical residency, he went to the United States to work in a research lab, a very good one, the lab of Professor Cloner in Los Angeles, that is very well known for everybody working in experimental cardiology or in cardiology, and spent there 2 years, and then came back to France, to Lyon, and worked there as a cardiologist again. He became professor of the University of Lyon, professor in physiology. And actually he created a department of diagnostic cardiology that is part, or is the department of physiology of that university. So he's now the chief of the Department of Diagnostic Cardiology of the Cardiology Hospital of Lyon. It's actually the Cardiology and Pulmonary Hospital, which is a very big one hospital. I don't remember the number of beds, but it is like this. This is huge. And in this hospital, he developed a research program on infarct size and reduction in patients with acute coronary syndromes and infarct size limitation. And this program was run simultaneously in two arenas. First, in the Inserm unit dedicated to basic research in cardioprotection, of which he is the chief, and he is also the chief of the clinical research unit in his hospital. And with these two instruments, he succeeded in running a very productive career with excellent production in this field of cardioprotection from bench to bedside. I think that the field of cardioprotection, of protection against reperfusion injury, has been developing for a long period of time, accumulating knowledge, but what was missing in this field is translation to patients, proving that that concept, that treating patients at the time of reperfusion could be beneficial and could save cells and could thus reduce infarct size, which can be also extrapolated for the brain and for other organs. And this should be proven, and I think that the most well-known and probably the most important contribution of Dr. Ovize has been to publish a series of relatively small proof-of-concept trials in clinical journals showing that this is really possible and that this is a new field that should rapidly develop in the clinical field, in the clinical arena during the next years. So Dr. Ovize is very well known, as you can imagine, for cardiologists, and he occupies a series of positions in different international committees and organizations. He is now the chairman of the working group on cell biology of the European Society of Cardiology, and he is also a member of the European section of the International Society for Heart Research, among other positions. But I think that overall he is an excellent clinician and an excellent translational investigator, and an example then to follow for a lot of our residents, of our cardiologists and our students. So it is indeed my pleasure to introduce Michel Ovize.
Thank you very much for this very kind introduction. And dear Cheers and dear colleagues, first I would like to say a few words on what I've seen this morning. I'm very impressed by your presentation and the way this institution is obviously progressing, and this is an example for my own institution. We are, in fact, way back with respect to what you do here. And the second thing I would like to say is that David Garcia Dorado, this is not because he just said a few nice words on me, was way up front in the description of reperfusion injury 15 or 20 years ago, at a time where nobody was able to say this is right. He was one of the first to describe what I'm trying to now present as real for patients. He was one of the basic scientists that described what we call reperfusion injury. So I would like to present today that we can do translational medicine and apply to patients what has been shown in experimental models and what we call postconditioning, for example. What is that? The first thing I would like to remind you is that when we talk about patients with acute myocardial infarction, the prognostics of this patient, the mortality after 6 months after acute myocardial infarction, is directly proportional to the amount of myocardial tissue that has been destructed, that has been irreversibly damaged by the acute myocardial infarction. So another way, infarct size is a determinant of mortality in acute myocardial infarction patient. The second thing is that in 2003, in the United States, Vinton Johnson group described a phenomenon called postconditioning by analogy to another phenomenon that has been described 25 years ago, that is preconditioning. What does that mean? If you occlude a coronary artery in an animal model, just like it is the case in patients with acute myocardial infarction, and if you pre-treat these patients or animals by performing brief
ischemia and reperfusion before the index ischemia, then you reduce infarct size by, let's say, 40%. But then Zhao and colleague repeated the same experiment, not before ischemia, but just after. After reopening the artery, which is the mandatory act you could do in patients, but briefly reocclude the artery for seconds or 1 minute, 3 or 4 times, then you end up with the same protection, that is a reduction of infarct size by 40%. Then this is very interesting in a theoretic way for patients, because you can do this, you could imagine to do that in patients and try to reduce infarct size. And this is the best and largest amount of tissue you can salvage by any means. So then David and others put together this scheme that is a new concept of what is infarction. In fact, if you imagine the infarct size on the y-axis, in fact, you can imagine that infarct size is due to 2 different things: the damage to the heart during ischemia after coronary occlusion, on top of which comes another damage after reperfusion, that is a reperfusion injury. In other words, if you consider the damage to the organ at the end of everything, it's a 2-component damage, an ischemic damage and a reperfusion damage. And this is a new concept. And we, as a clinician, know that we can fight what we call ischemic damage, but we have nothing to fight reperfusion damage. We use drugs like beta blockers, ACE inhibitors, statin, etc. All these drugs are, of course, very interesting for patients. They save lives, they improve the outcome, but they do not act by reducing infarct size, which is the major determinant of prognosis in this patient. And as I said before, we have no drugs, nothing today for our patient to fight reperfusion damage that is 40% of the overall damage. And there is a limitation to that. Postconditioning protection has to